I will talk about delayed puberty in males, definitions, etiologies, and diagnosis. As you know, we use standard stages to describe the course of normal puberty. Stage 2 marks the beginning of puberty, and at this stage, there are practically no changes in the scrotum or in the size of the penis, and it is mainly characterized by reaching a testicular volume of 4. We define pubertal delay as the start of puberty at an age greater than 2 standard deviation score from the mean of the population. If pubertal onset has a Gaussian distribution, then approximately 3% of normal boys will initiate puberty late. The mean age of pubertal onset is about 11.5 years, which is why we define pubertal delay when puberty begins after 14 years of age. And we define abnormal absence of puberty when a boy older than 14 years had testicles less than 4 milliliters. There are other disorders of puberty that also deserve our attention. For example, unarrested puberty, that is a puberty that starts at a normal age and do not progress, or a slow progressing puberty, that is a puberty that begins at a normal age but does not progress properly. And what is properly? In this table published many years ago by Marshall E. Tanner, we see the duration of each pubertal stage. And you can see that male puberty requires 3 years to reach Tanner stage 5. As you know, the testicle is composed by 2 compartments, the interstitial compartments where the ladies' cells are and produce testosterone, and the tubular compartment where the germ cells are, which in the future will produce sperm, and Sertoli cells which produce anti-Mullerian hormone and inhibin B. It's important to know that we define hypogonadism as decreased testicular function involving a disorder of gamete production and or a disorder of Leydig cell hormone production and or a disorder of Sertoli cell hormone production. Compare with what is expected for the age of the patient. In the right, you can see that gonadotropins and testosterone secretion increase until about 6 months of age, and thereafter they decrease to very low or undetectable levels, and at puberty, LH, FSH, and testosterone increase again. AMH and inhibin B remains at high concentration during all childhood, showing us the activity of the testes. At puberty, AMH decreases in response to the inhibition exerted by androgens and inhibin B increase. So, we can understand childhood as a physiologic hypogonadotrophic hypoandrogenism period. So, LA gonadotropins are low, androgens are low, but AMH and inhibin B are high. When we study a patient with delayed puberty, we must differentiate whether it is only a prolongation in time of this period of physiologic hypogonadotrophic hypoandrogenism, or it is a pathological hypogonadism. Male hypogonadism can be classified according to the level of the hypothalamic pituitary gonadal axis that is primarily affected. That is, it can be a testicular or primary hypogonadism. I don't like to use the word hypergonadotrophic in childhood because you know that not every testicular hypogonadism have high gonadotropins during childhood. Also, it can be hypothalamic pituitary or central hypogonadism or combined. Also, hypogonadism can affect all the testicular cell population, that is a whole gonadal dysfunction, or it can affect only one population of testicular cell. And finally, hypogonadism can be classified in congenital or acquired, depending on the period of life in which it is established, and in fact, clinical consequences are different. Seldelmeyer published some years ago this large series of childs with delayed puberty and their etiologies. It is a very nice paper. We can see that more than half of the patients, 63% of the patients, had constitutional delay of growth and maturation. 20% have functional hypothalamic pituitary hypogonadism, 9% congenital hypothalamic pituitary hypogonadism, 7% testicular hypogonadism, and obviously, in some patients, you cannot make the diagnosis. Most of testicular or primary hypogonadism involves all Sertoli cell population. It can be congenital. Examples are anorchidism, cryptorchidism, or it can be acquired. For example, bilateral orchitis, surgical or traumatic gonadectomy, chemotherapy, etc. In children with anorchia, gonadotropins vary through life. They are high in the first years of life, then they decrease during childhood, and a percentage of them normalize their gonadotropins. You can see that after 10 years of age, gonadotropins increase again to very high levels. Therefore, at the age in which a child consults for delayed puberty, basal gonadotropins allow us to rule out the diagnosis of primary hypogonadism. The other cause is constitutional delay of puberty, that it is the most frequent cause and represents one extreme of the normal spectrum of puberty. The diagnosis is made by exclusion, and the consultation is much more frequent in boys than girls, in part due to the greater social pressure concerning the absence of pubertal changes and the short stature, but also we can see that maybe a genetic explanation participates. It's very common to find a family history of delayed puberty in one or in both parents or brothers, which supports the hypothesis that there are a genetic basis in delayed puberty. However, we have to be careful. If we see that one or both parents have delayed puberty, we don't make the diagnosis of constitutional delay of puberty. We have to know that central hypogonadism has different expressivity. So, in some families, we can see that an affected child has a central hypogonadism, and his parents with the same mutation present with delayed puberty. So we have to be careful with this information. It's common to observe a prepubertal growth velocity, prepubertal levels of EGF1, a relative deceleration in high versus his peers, a delay bone age, low bone mineral density compared with according with bone age, and short stature, but that is according to bone age also. As I already told you, we can understand the constitutional delay of puberty at a prolongation in time of the transient hypogonadotrophic hypoandrogenism in childhood. Here you can see the prolongation in time. Other cause of puberty delay can be an hypothalamic pituitary or central hypogonadism. In most of these cases, it involves all Sertoli cell population, but there are some exceptions. For example, if you have a mutation in the beta subunit of LH. Central hypogonadism can be partial or can be complete, can be multihormonal, like the case you presented before, or can be isolated, and can affect olfaction or not. Boys usually present with normal stature but an absence of pubertal spurt and a mild delay of bone age. Diagnosis of central hypogonadism is really not easy. A good physical exam is very important. You can find the classic triad of micropenis, cryptorchidism, and microorchidism, or sometimes you can find one or two components of this triad. Puberty can be absent or incomplete. We have to look for other hormonal deficiency, and also we have to look for associated clinical findings like synkinesia, deafness, syndactyly, dental agenesis, cleft palate, and others. A central nervous MRI with a special coronal section is useful to identify aplasia or hypoplasia of the olfactory bulbs and sulci. Olfactometry could help us to identify olfactory disturbance. Many of us cannot make an olfactory test in our practice every day, and we use anamnesis. We have to know that anamnesis is a very good test to diagnose anosmia, but it's not good to detect hyposmias. We have to ask about history of micropenis and cryptorchidism and their treatment. You know central hypogonadism does not result in genital ambiguity, since lady cell function in the first trimester of fetal life depends on placental HCG and not on fetal pituitary LH. In the second and third trimester of fetal life, the production of testosterone depends on fetal LH. During this period, testosterone mainly participates in the growth of the penis and in the testicular descent. Therefore, congenital central hypogonadism results in micropenis and cryptorchidism. Regarding the pathophysiology of microorchidism, FSH stimulates Sertoli cell proliferation and AMH and inhibin B production. The prepubertal testis is mainly composed by Sertoli cells, which represent more than 75% of gonadal mass in childhood. Microorchidism in central hypogonadism is the consequence of the insufficient stimulation of SH on the Sertoli cells since birth. Indeed, we can see in untreated adult patients with central hypogonadism that AMH, anti-Mullerian hormone, is low compared with its standard stage. When we treat these patients with FSH, AMH increases, and the same happens when we see inhibin B. Central hypogonadism can be associated with other clinical findings according to the affected gene and where it is expressed during embryogenesis. In fact, in the candidate gene molecular approach, the existence of these clinical findings guides the study of a particular gene. But it's important to know that we are not going to find them if we don't look for them. For example, we have to ask for an abdominal ultrasound, and we have to ask for an audiological evaluation. Central hypogonadism can be congenital or can be acquired. In acquired forms, we can find organic forms that are usually permanent, and functional forms that are usually transient. Organic forms, examples of organic forms are central nervous system tumors, histiocytosis, radiotherapy, surgery, head trauma, infections. It's very important to make a good physical exam and a good anamnesis. Headaches, visual disturbance, vomiting, other pituitary insufficiency, polyuria, and polydipsia. In the transient form, in the functional forms, there are a lot of cases. It's an hypogonadism that results in response to another disease. If this other disease resolves, the hypogonadism also reverts. The classical example of a functional hypogonadism is anorexia nerviosa. But we have to know also that there are some functional central hypogonadism of endocrinological cause. For example, in a patient with hyperprolactinemia or in a patient with severe hypothyroidism. When we want to study a patient with delayed puberty, we ask for biochemical studies, a renal and liver function, blood count, celiac disease antibodies. All of these rule out functional central hypogonadism. Then we ask for prolactin, IGF-1, cortisol, thyroid profile. These allow us to rule out endocrine functional central hypogonadism and other pituitary insufficiency. Finally, we ask for gonadotropins, testosterone, and AMH. As I already showed you, with this, we can rule out testicular hypogonadism. And finally, we must face the most challenging task, which consists of differentiating between constitutional delay of puberty from central hypogonadism. The classic gold standard is clinical evolution, but we can use also basal testosterone, basal gonadotropins, stimulation test, and Sertoli cell peptide. What is the clinical evolution? Is waiting until 18 years of age. Did puberty start? If it didn't start, we diagnose central hypogonadism. If puberty starts, we have to wait 4 years and see if the puberty complete. If the puberty complete, it was a constitutional delay of puberty. If not, maybe it's a partial central hypogonadism or an acquired central hypogonadism. Very nice, but this approach does not take into account the feelings and the emotion of the patient who asks for help with a delayed puberty. Basal testosterone has bad reputation, but what we have to know is which is the information that testosterone can give us. On the left, we can see the results of one study that evaluates the utility or predicted value of testosterone level. We can see that all patients that have a testosterone level over 50 nanograms per milliliters are constitutional delay of puberty. And we can see also that if testosterone is below 50, we cannot use it to differentiate both diagnoses. In another study evaluating patients with delayed puberty, we can see that 100% of the patients that present with a testosterone levels over 20 nanograms per deciliters begin puberty after 15 months of the evaluation. But only 22% of patients with testosterone below 20 begins puberty after 15 months. Basal gonadotropins can be useful. L8 before 0.4 and FSH below 1.2 with IFMA has a very high positive predicted value for central hypogonadism. Obviously, it depends on the methodology you use. A very nice way to identify the beginning of puberty is to evaluate nocturnal pulsatility of gonadotropin secretion. On the top, we can see it in diagrams, the absence of pulse in a prepubertal child, the asynchronic pulse in early puberty, and the synchronic pulses in puberty. Below, you can see a real paper showing the difference between a group of patients with constitutional delay of puberty, where you can see the pulses, in some cases asynchronic, and the absence of pulses in central hypogonadism. Concerning stimulation tests, there's a lot of stimulation tests described. And every time you see a lot of tests, the explanation is that any test is ideal. Most of the big problem of this test is the overlap between groups, especially in partial forms of central hypogonadism. Our group published several years ago a paper that evaluated the usefulness of prolonged infusion of 100 micrograms of GnR rate for 120 minutes. The objective of a long test is to evaluate the release of previously synthesized gonadotropins, but also the synthesis de novo. Using ROC curves, we determined the cutoff values and we elaborated an algorithm. If you see a patient with delayed puberty or suspicious of central hypogonadism, we first make basal gonadotropins. If FSH is below 1.2, we can make the diagnosis of central hypogonadism. If not, we'd make a GnR rate infusion test. If L8 and FSH peak are below the cutoff, we diagnose a central hypogonadism. If not, we diagnose a constitutional delay of puberty. Remember that even this proposed algorithm is not 100% has some overlap between both groups. Sertolian markers may be useful in the study of a child with delayed puberty. We remember again that constitutional delay of puberty is a prolongation in time of the physiological hypogonadotrophic hypoandrogenism of infancy. Then, when we evaluate a patient with delayed puberty, we will observe a biochemical profile typical of a normal child. LH, FSH, and testosterone will be low as a prepubertal child, but AMH and inhibin B will be high, like a normal child. In contrast, in a patient with central hypogonadism, LH, FSH, and testosterone will be low, but AMH and inhibin B will be very low also. Why? Because, as I already told you, FSH is essential for Sertoli cell proliferation and AMH production, and the boy with congenital central hypogonadism was exposed to abnormally low levels of FSH since birth. Finally, molecular diagnosis may help to confirm the diagnosis. In recent years, thanks to new techniques in genomic study, the number of genes described associated with central hypogonadism has had an exponential increase. However, we have to know that even with this advanced technique, the genetic cause can be found in only half of the patients with confirmed clinical and biochemical diagnosis of central hypogonadism. Thank you very much. Thank you very much for this invitation, and I want to thank also
Hello. Hello.
Yes, ma'am, we can hear you.
Hi, Romina. Thank you so very much for your wonderful presentation. Obviously, years of work truly kind of comes across through the entire presentation, and your depth was amazing. Would you like to touch upon the management aspects at all, or would you consider that difficult? Would you like to talk to us about management, like a newborn who presents with micropenis with a possibility of a background of multiple pituitary hormone deficiency? How would you manage that child for hypogonadism versus an adolescent with hypogonadotropic hypogonadism? And when would you like to consider switch from gonadotropin to testosterone regimen in an adolescent who's not looking forward to fertility?
Yes, you know that in this talk I did not include treatment because the time was very short. The topic was delayed puberty, so I didn't include neonatal treatment or the difficulties to diagnose hypogonadism, central hypogonadism during childhood or during infancy. During adolescence, when we see a patient, what we have to evaluate is which is the feeling of the patient. The patient is suffering because of the lack of puberty, or the patient is okay and the problem perhaps is the mother. If we study the patient and we diagnose that it's a constitutional delay of puberty, we can talk to the patient, explain what is our idea, and see if the patient can wait to see if puberty begins. If we cannot make the differential diagnosis, or if the patient is very anxious to start puberty, we then start treatment with testosterone. In our service, we use testosterone enantat intramuscular. We start with 50 milligrams, and we see the evolution. There are two ways of making this. One way is make 6 months of treatment with very low doses of testosterone. The emotions of the patients change a lot with these 6 months of treatment. We can stop treatment after 6 months, or in some cases, we continue treatment but paying special attention to the change in the volume of the testes. If we see that the volume of the testes increase, we stop treatment to see if puberty progresses. I think that it's a very, very good idea to start treatment in the patient with central hypogonadism with FSH, but until this time, this is experimental. Did I answer?
Yes, please. Certainly you did. Yeah, sure. And do you kind of have a take on newborns who present with micropenis cryptorchidism with a possibility of hypogonadotropic hypogonadism as a part of maybe multiple pituitary hormone deficiencies? Do you treat them with gonadotropin-based regimen to mimic mini puberty?
If we use gonadotropin treatment in neonates?
Yes, in the infant to mimic mini puberty.
We don't do that because we don't have a protocol, and this is also experimental. But I really believe that mimic the normal physiology is a very good idea. But those patients that were published until today that were treated with L8 or HCG and FSH are not pubertal yet. So we have to wait until these patients are published and see if spermatogenesis really is better with this treatment. When this is proved, treatment will change to be from being experimental to be a real practice. But if you ask my opinion, I really believe that mimicking the real physiology will have a good response.
Lovely, sure. I think that's a very valuable comment.
Totally. Paying attention to Sertoli cell, because FSH stimulate the proliferation of Sertoli cell. If we don't have a good population of Sertoli cells in the future, we will not have a good spermatogenesis. So I think it's an interesting idea to see all the population of the testes.
Wonderful, yeah. There's a kind of a question here in a chat box, and it says it's from Professor of Endocrinology at southern part of India, Dr. Vijaya Sarthi. His question is, what is the LH cutoff that can give specificity of 100% to confirm the diagnosis of constitutional delay on GnRH stim test?
I showed you the results of the infusion test. If you have a level of L8 before 5.8 in a stimulation test and a level of FSH below 4.6, you can make the diagnosis of central hypogonadism with a good accuracy. But if you don't have the levels of gonadotropins below this cutoff, you cannot be sure that it is a constitutional delay of puberty. That is why I told you that it's a very difficult task to differentiate both diagnoses. Um, I, I know that I want to make some publicity. AMH is very useful in those cases. When you have a congenital central hypogonadism and you have a low AMH, the predicted value is very high. It's really very high. If you have 100 picomole per liters of AMH, you have the diagnosis of central hypogonadism. But if AMH level is normal, you have to wait. Sometimes you start treatment, but final response, you will have it with time.
Lovely. Do you have a cutoff in mind for inhibin B in the same lines to differentiate CGDP from central hypogonadotropism?
No. We are making a prospective study to evaluate the utility of AMH and inhibin B to differentiate both diagnoses. But I don't have, it didn't finish yet because they are very long studies, because you incorporate the patient when at 14 years old or at 13 years, and you have to wait 5 or 6 years. And if the patient is 17 years when he starts puberty, you have to wait 4 years more. So these kind of studies are very, very long. But there are some published papers that are very nice. I don't remember the cutoff, but you can look for these papers. But what they say is that inhibin B show to be more useful than anti-Mullerian hormone. Why? I think that the reason is that androgens decrease the levels of AMH. So when the boy is starting puberty, this inhibition of androgens make you confused. Inhibin B is different because at puberty it increases. And that's the reason why perhaps inhibin B is better than AMH. But I cannot tell you exactly the cutoff.
Fair enough. Absolutely agree and understand your predicament in putting together the need for so-called cutoff, which is so difficult. Along the same lines, for the comment that you made that you get worried about the Sertoli cell population, which is what you're trying to build up in all these patients with possible suspected central hypogonadism versus a possibility of either a physiological delay. Are you concerned of using testosterone and just knocking off the Sertoli cell population or maturing them prematurely, vis-a-vis allowing them to proliferate?
I cannot answer exactly this question. There's a very nice paper that compare a group that used testosterone first with other group that start with gonadotropins. I think the author is Rojayen, but I had bad memory. And they showed that the future spermatogenesis was not affected in the patients that started testosterone treatment first.
I'm sure you have studied this very, very in depth and extensively, but our own data suggested that in more severe patients with hypogonadotrophism, which is central in origin, a pre-treatment period with testosterone does compromise their sperm concentrations vis-a-vis just gonadotropin-based regimen. So that's a published data
Yes,
work. So I just wanted
yes.
to say that we had a little different experience.
What you say is it's logical. It's what I think. I told you that I would like to start treatment in an adolescent with FSH before adding HCG or testosterone if in some cases. But I didn't see that the long results that support this idea. But the response is yes. I think that assuring a normal population or a better population of Sertoli cells would be the ideal thing to do.
Sure, I understand. There's one more question here from Pragya Mangala. Um, she kind of wants to understand that for preventing possibility of a low bone mass, is there any particular dose which is recommended to be given? I'm not sure I understand the question. So, Pragya, are you referring to testosterone dose for
In fact,
functional hypogonadotrophism?
yes, I understand.
Okay,
Um, I prefer not to treat hypogonadism in functional hypogonadism if I think that the illnesses is going to get better and get cured. Because when the illnesses resolves, the patients make like a gap in bone health, a gap in growth, a gap in everything. Only in some cases that I talk with the other doctor that is treating the patient, and I see that the patient has fractures, or it's the affection is very prolonged or very profound. Well, perhaps then I decide to treat with a low dose of testosterone. But the idea that I want to transmit you is that this hypogonadism does not need to be treated with testosterone. In patients with anorexia nerviosa, a lot of times we have not to start we don't have to start treatment with estrogens. We have to wait when the weight and the psychological status is better. The patient, the hypogonadism is will be resolved itself.
sure, I understand. Romina, do you think there is a role of Sertoli cell in testicular descent?
No, I don't know. I don't think so. But there is some bibliography that suggests that AMH participate in testicular descent. I personally don't think that this information is enough to say that Sertoli and AMH participate yet at this moment.
Okay, sure. I